Hello, I'm Lorette Ligon, President of the Jacksonville-Onslow Chamber of Commerce, and I want to thank you for joining us for this all-important Forum Onslow. At this time, I would like to recognize the elected officials in the audience and thank each of you for your dedication and service to our community. Representing District 6, North Carolina State Senator Mike Lazzara. My dear friend representing the 14th District, North Carolina House Representative George Cleveland. Onslow County District Attorney Ernie Lee. And we have wonderful representation from the Onslow County Commissioners, Royce Bennett, Robin Knapp, Mark Price, and Walter Scott. Also with us today, Onslow County Sheriff Hans Miller. And last but not least, Jacksonville City Council member Brian Jackson. The Chamber works with government agencies on issues that affect our business community. We monitor legislative issues that impact local businesses. We promote partnerships between business, government, military, and education. And we use these forums to create awareness on topics that are important to the entire community, such as the ongoing crisis of the opioid abuse. We are pleased to have Onslow Memorial Hospital, an affiliate of UNC Healthcare, as the signature sponsor for this forum. At this time, I would like to turn the podium over to Dr. Penny Burlingame Deal, President and CEO of Onslow Memorial Hospital.
Thank you, Lorette. I feel I should say I'm not worthy to be in the room with all of you. What a great group of people here to speak on a really important topic. But welcome to Forum Onslow, an ongoing discussion about the continuing ongoing crisis for opioids. It's been around for a long time, but unfortunately, the discussion around that has been eclipsed by COVID-19 for the past 2 years, definitely going into the third year now. I will also say, though, it's likely contributed to this discussion and this issue that we have right now. Who knew that 2 years ago, when we entered into this pandemic, that the very mechanisms we put in place to protect us from further transmission of this virus, wearing a mask, covering our face, right, social distancing, that would contribute to a feeling of social isolation. And that feeling of social isolation actually exacerbates mental health issues, which tends to exacerbate self-medicating behaviors. So I think that COVID has actually probably made this worse, and a very relevant topic for discussion right now. So I will say that I am thrilled to be in the same room with all of these community leaders who are going to serve on a panel, a wonderful panel of experts who will tell you where we are in Onslow County, the status of the opioid crisis in Onslow County. So thank you all for being here. And with that, I get to introduce, representing District 6, the North Carolina State Senator Mike Lazzara.
Thank you, Dr. Penny. How wonderful is it for us to be able to be here together in the same room without masks and without social distancing, or those of you that would like to wear masks, we don't discriminate. But it really is nice to be able to gather together again. It just seems like it's been so long that we were at the last opioid forum that we have, which was very productive. So the reason we're here today is to talk about opioid abuse. And for those of you that know me, know how passionate I am about this topic, particularly in our community and throughout the state. Opioid has been around for a long time, and some years ago, the numbers really spiked in our area, and community leaders got together, and we decided that we were going to try to combat that. And as a result of that, we accomplished some really great things I'll talk about in just a few moments. But we were lowering the numbers of the overdose rates, and we were feeling really good about the path that we were headed in. And then all of a sudden, we had a little virus that sort of changed things a little bit, as you just heard about earlier. With the pandemic, the numbers have become staggering, and unfortunately, we've gone the other way. Just to share with you some of the numbers that I'm talking about are this. In 2020, we had 92,000 overdose cases in our country. 92,000. 21,000 more cases than the prior year. That's a staggering number. And you ask, what's causing these overdose rates? Well, 87% of them included fentanyl. Synthetic opioids is what's killing our family members, the people we love, sons, daughters, mothers, fathers, aunts, uncles. There's no social class when it comes to addiction. It affects everyone at any class level. I can't imagine there's anyone, even sitting in this room today, that doesn't know someone that's affected by this issue. And we can relate that to mental illness because it's all in the same category. People that are struggling one way or another. And the reason we're here is because we want to be the voice for the voiceless. As a result of what we did together as a community years ago, we got together and we decided that at that time we didn't have a crisis center here locally. We had gone through some centers in the past, but they were not successful and they ended up closing up. And so we got together and were able to open up the Dix Crisis Center that included multi-county participation, which is one of the first in the state. And we were proud to be able to put that together right here in Onslow County. It's only a 16-bed facility. It's the Dix Crisis Center, which RI International is the provider there currently. But it's a 16-bed facility, and it's a multi-partner organization that we're providing services in. We, through the help of the DA, the Sheriff's Department, Police Department, we have diversion programs, and where we can get some of our youth at an early age that somehow have been affected with drugs to get them back on the right path without giving them a criminal history. Finding a pathway. Because those of you that are around this particular disease know that incarceration is not a solution. We can't incarcerate our way out of the opioid crisis. People that get involved in it, that become addicted to it, they're typically great human beings, extremely intelligent, extremely gifted by one way or another, whether it was through an innocent party, an injury, just some innocent way become involved with the opioid drug, and then next thing you know, they become physically addicted, mentally addicted, and there they are. Great human beings on a road that none of us would ever want to be in. As part of that center, we also developed a financial assistance program. Because many of the folks that go through there, it's a 5 to 7 day stay, and basically it's a transitional facility, basically de-escalating, getting folks stabilized, and then moving them on to either long-term care, outpatient care, or some other method of care, and that sometimes requires entry fees or some other fees that will allow them to go to the next phase. And we have a scholarship program here locally that allows that to take place, and that's been also a very effective tool. We talk about fentanyl being the synthetic opioid substance that's actually killing folks. You all heard just recently what happened at one of the academies. I think 3 or 4 folks overdosed, and they were snorting cocaine, and cocaine was laced with fentanyl, and it killed them. Fentanyl is being put in marijuana. Something as simple as marijuana now at the school level. Kids don't know. They think they're smoking some marijuana, being cool, and next thing you know, they're dead. So one of the things that we did at the General Assembly is I sponsored a bill, and it actually passed and signed by the governor, was moving fentanyl from a misdemeanor to a Class I felony. Now, will that take care of the problem? Probably not, but it certainly will hopefully make some folks think twice about it, about selling it. In our budget this year, we had $16 million in opioid funding for recovery. As you know, there was a case that got settled. I think there's an additional $16 million that was reaped from the pharmaceutical agencies, and I think RDA was involved in that, and the Attorney General. So there's money being funneled in that direction. Also, as part of the budget, we secured $3 million for the 23-hour facility, which is the front part of the Dix Crisis Center, to give us some additional capacity in the event that the beds are all taken, that we can have folks in the front part of the building to get them de-escalated, to get them settled down, and hopefully while they're there, get them a bed either in our facility or maybe another facility somewhere else in the state. So we're very proud of that, and we're underway in trying to make that happen very soon. These are things that we continue to do. One of the other things, I sit on the judiciary oversight, and we're working really hard in our prison systems to develop programs within the prison systems that are true drug treatment programs. Again, jail is not the answer. It's appropriate in certain situations, but most of these folks are in jail because of their drug abuse and what they've got to do to keep getting the fix that they need. And they typically do something they shouldn't be doing, and that's why they end up where they are. But we need to make sure that we get them treatment. And that's something that we are working on and we're very proud of, and there's money that will be funneled down that road to make that happen. And then, as well as part of our budget, we also have monies that throughout the state giving support to recovery organizations of various kinds. We know recovery is the key to success, but we also know that we've got a lot of work to do in the recovery realm of this process. Okay? We still have a lot of work to do. Medicated assistance is becoming sort of, not the new deal. It's been around, but you're hearing about it quite a bit. And so you'll hear a lot about medicated recovery, but you have to understand that medicated recovery is good while you're in a center. As soon as you leave that center, if you don't have insurance, guess what? You're not going to be able to continue that medicated assistance recovery program. So we've got a lot of work to do still, and we will continue to be obligated in doing that. And you have a delegation that is very concerned about our community and the opioid crisis, because again, you've heard me say this in the past, and I'll continue to say it. If we can save one life, then we've done our job. But we've got to save one life. We're losing too many family members. We're losing young kids at early ages, sons, daughters. We can't just sit back and be complacent. One of the other things that before I introduce our panel and move on, is I didn't touch on how great our local law enforcement agencies, our sheriff's department, our police department, our narcotics are doing in their part of eradicating drug dealers and drug traffickers in our area. And I would ask you to please give them a round of applause. That's not an easy job. Very dangerous. A very dangerous job, and they do a fantastic job, and they continue to get these folks off the streets. Just recently, and I'll have the sheriff talk about it later, got a big bus that took a lot of fentanyl that could have killed, I guess, the total residency of Sneed's Ferry. But anyways, my pleasure to be here, and I'd like to introduce our panel. We got a lot to talk about today. So with us today to have a discussion is Dr. Tobi Gilbert, to my right, Police Crisis Counselor Julia Neal, who's the site director for the Dix Crisis Intervention Center, Lee Stiles with COSSAP grant. He is the coordinator for the COSSAP grant that we have local. I want to thank our panelists for joining us today. We are going to pose the series of questions to them, and then what we would like is to open up for some questions from the audience that our panelists can answer. So let me get right into it, okay? And one or more can answer the same questions, but I'll start off with, what additional treatment resources are available for opioid addiction in our community? Are there any effective programs or treatment centers within the North Carolina Department of Correction? So let's start with the first one. What additional treatment resources are available for opioid addiction?
Okay,
Gilbert?
I can answer that, Senator Lazzara.
Thank you.
Okay, as far as Onslow County, we can start off by talking about Diggs Crisis Intervention Center again. They're a detox facility, so when people make the choice to get clean, that's their first stop, is to go to a detox facility. Especially when you're coming off opioids, you need to go to detox first before you can go to a rehab facility. One of the barriers I have seen is that a lot of these individuals have trouble getting to the facilities, so I feel like we need to open up more transportation opportunities for the people who want to go to detox, because we have a 24-hour window with individuals who want to get clean. If we don't get them the resources they need within that 24-hour window, they're going to go right back to that addiction. So it starts with detox. And as far as rehab facilities, we have several in this area and surrounding areas. Hope is Alive Rehab, they just opened up a women's house in Gilbert. I met with Miss Heidi McWilliams. She's the director there. She has a story of recovery, so she can relate to the women at our house there. They're doing an amazing job. I just had a friend that went through that program, and that program is very vital to what we're doing here in Onslow County, and we got several others in surrounding areas. We also got Mr. Robert Cooper, who is on hand right now. He's here in attendance. He has 0 Hour Life Center. They're based out of Florida, but he has branched off and started doing things here in Onslow County. So he's another resource. And to answer your question, Senator Lazzara, about the prison system and having resources there, I'm going to say that I'm a product of the prison system. I've been in prison twice. When I was in prison, the only resource that we had was DART. And certain individuals are eligible for DART. If you were diagnosed with mental health or substance abuse issued by a clinical counselor or a psychiatrist, you were eligible. But DART wasn't available to many people. It wasn't available to me. I had to take the faith-based route to recover from my addiction and my issues. But DART was the only program that was available when I was in the penitentiary. I love to hear you say that y'all are trying to start more programs inside of the prison system, because that's going to be vital, because it starts there. Because a lot of times when these people get incarcerated for their substance abuse issues, we often leave them alone when they get released, and they're forced to go back to a society that not only looks down upon them because of the stigma of addiction, but a society that has failed to provide the essential resources for them to succeed. As y'all can see today, you're talking about somebody who used to run from people like Chief Yanero and Sheriff Miller, to now I'm speaking in front of them, and I'm on a team with them trying to help solve this problem and trying to be a solution instead of the problem. So it's many other people that are in the prison system right now, and they are just like me. But we need to reach those people. We need to give them the resources they need, and we need to stay in contact with them, because those people have the potential to be productive citizens, but they're reaching out for help, and they don't know where to go to.
And I will add on to what Lee is saying, that there are some other resources in Onslow County, such as the Jacksonville Treatment Center, which is predominantly a methadone-based treatment center, though it does do buprenorphine and some Suboxone and some other type of MAT or medication-assisted treatment. There are some local outpatient treatment centers, such as Port, Again, Dick's has some outpatient treatment as well as the inpatient detox and mental health center that they have, and some other just outpatient centers that will address and do some substance abuse assessment. There's really quite a few. Now, the barrier that, again, does come up is the financial component, because though Medicaid does pay for buprenorphine, there is still somewhat of a cost to the individual. And some of our local agencies and companies do not accept uninsured. So of course, cost is going to remain a barrier, and funding and transportation will remain a barrier right now until we continue to wrap our heads around how we can resolve that potential or that particular issue, which we are continuing to try to address in our different task force. And that's where partnering comes up, and we are really truly working on that. So though it is and will continue to be an issue we address with respect to the substance abuse, the big thing is us continuing to develop our partnership, and anything anybody can add as we bring people together with us is vital to the success of this community. And we have very strong partnerships, but we're always looking for more partners that can add and contribute any little bit, whether it's volunteers, whether it's time, whether it's just ideas. We're very open and welcoming to that, because this is a huge problem in our community. And as the senator said, our numbers shot up when the pandemic said, and as Dr. Burlingame said, this pandemic has done more damage than I think we really realize as a community, to our mental health, to our substance users, to our families, to our governments. It's very, very costly. And if we want to get our costs back down, the only way to address this is together. And I do appreciate you all being here, because we have to put our brains together to make this work.
Thank you. Julia?
Yeah, so, hey everyone. So I would say that from my perspective, the strongest measure of success that we have currently here in Onslow County is the combination of the medicated assisted treatment program and housing. So we find that with individuals who have had numerous relapse experiences in their life, or they've come back to the facility a few times, that has been a really strong factor in their success. What I will say that Lee and Dr. Gilbert have both emphasized is that we do have a lot of these programs here in Onslow, but we have one, or we have maybe two. And so when you think about it, that's excellent. It's wonderful that we have these, and it's a starting point. So for my little nucleus at the facility, we serve an average of about 800 Onslow County residents per year. And when you think about that number, about 60% of those individuals are coming in for substance use. So where are those individuals going? They're utilizing the services that we have, but there may be waiting times, right? There may be one avenue, one service that they can access. So I think what's really excellent is that we have them, and it's about achieving potentially more of the same thing, because I think what we have works. We're just working with numbers as well when it comes down to it.
Thank you, Julia. And as a follow-up question, let's talk about how long do y'all think it takes for someone to overcome an opioid addiction? I know that I helped get a few folks into TROSA, and they've been there over 6 months, and they're thriving and doing well. Can you talk about, and it's a 12-month program, can you talk about how long does it really take for someone to get their feet on the ground and really have an opportunity to move forward with this sort of addiction?
There's no set time when it comes to addiction. I've got friends that have been to 6 or 7 different rehab facilities. They've been in and out of detox for years. And it may take that 8th facility for them to go to for them to overcome their addiction. I got other friends who all it took for them to go to detox one time, and now they're clean and sober, and they're doing great. So it's no set time, Senator Lazzara. But I want to say this, too, is that it's a lifetime process when we're talking about recovery. When we're talking about addiction, it's a lifetime process. It doesn't stop at a certain period of time. I just talked to some gentlemen that are here They have an organization, a team full of peer support specialists. Mr. Cooper here, he has a team full of peer support specialists. When these individuals are coming out of detox, when they're coming out of rehab, after they receive their treatment, after they become sober, these peer support specialists are vital because they're going to walk with them on a daily basis. So I really believe that we need more peer support specialists in this area. I heard that we have under 18 here. I know Cammie with Community Paramedics has 2 on staff there. And I know Julia has a peer navigator at Dix Crisis Intervention Center. But we need more peer support specialists in this county because this is a lifetime process. Even if somebody gets clean and they're clean for 4 or 5 years, there's always that window of opportunity for them to relapse. So that's why I'm also a firm believer in creating sober living environments right here in Onslow County, because a lot of these people are forced to go back to the same environment that they came from, and now they're sober, but they're going back to housing and where their family members are there, and their family members are getting high, and they're forced to live with these people. And what's that going to do? That's going to increase the chance of relapse. So we need to create more sober living environments, and we need to have more peer support specialists if we want to continue to walk with these people through this addiction process. So it's no set time.
I think the way I like to think about it is if every single person in this room had challenges with blood pressure, for example, if you take your medication and you see your provider, there may still be individuals in here who have worse challenges with their blood pressure than others, even if they stick to the recommendations by their provider. Those challenges could be due to not being able to exercise as effectively as someone else, not being able to eat healthily the same way as someone else, right? So when we think about substance use, it's kind of in that way as well. There's just so many other factors that could prevent someone, even with all the tools, to be able to experience recovery the same as someone else. And so that's what we're working on every day with someone, is that it isn't just that they're using that substance, it's that they have an extensive trauma history that is preventing success. They have challenges with houselessness or couch surfing. And so until there's stability in other aspects of their life, that may always be problematic, even if it's 2 years down the road or 15 years down the road or 2 days after they leave the facility.
What I want to add to that is a little bit of the physiological component of that as well, is that the physical addiction to substances is really only about 7 to 10 days from the physiological standpoint. The rest of it really becomes a psychological addiction. And the psychological addiction is really the longer component of moving through addiction, because that is the hardest to kick. It's like, for those who have been smokers and tried to quit smoking, the craving component of that is really about the behavior that goes with smoking, that always wanting to go to this after, stress or after dinner. It's always or generally paired with something you've been doing during the day, a routine. Or a stress level. It's the same thing with using different substances. It's usually paired with a routine or a psychological state of distress or running thoughts, something like that. So the physiological component is a much easier component to get through, because if you don't have access to it, you're not using it, you're going to get through that within a 7 to 10 day period generally. Again, it's going to depend on how much you've used and so forth, but that's a general rule. So when you're looking at that detox component does become very important in where you are, and that's why they also talk about in recovery, you need to change your place, change your habit, change your friends, because that becomes, you're already healing of the psychological process as well, but when you become very tempted is when you go back into your old habits, your old routines, because it's very easy to fall back into behaviors. So I agree with 100% everything they're saying. It's an individual process and an individual time.
Thank you for that. Let's move on to some statistics. We're being told that, or you read about, that Jacksonville is in the top 10 cities in the nation for opioid addiction, to include Wilmington, Hickory, and Fayetteville. Would you say this is an accurate statement? And if so, what do you think we can be doing that we're not doing to help lower this rate?
So I think when that report came out, that was the Cast Light report, I believe, that identified us in the top 10. And at the time, that was 100% accurate. I think that came out in 2017, I believe, 2018, when that came out.
19, yep.
And I pulled some current statistics from the NCDHHS website, and then I was in a meeting this morning with the overdose group from the state and around the state, and they had up-to-date 2020 statistics, and actually compared to the state at this point, there's 2021 statistics, I'm sorry, we are actually compared low across the state. And the state is at 150.8 on average, year-to-date stats, for ED visits for overdoses. Onslow, comparatively, on average, is at 130.3, and so we're on the lower side for that particular piece. And then I went ahead and compared us to Cumberland County, because we're kind of statistically matched with them. And
Cumberland would be Fayetteville.
Fayetteville, I'm sorry, you're correct. Find that. We were fairly matched with them. They were still remained a little bit higher than us. Find it. Sorry about that. Maybe I can find it. Yeah. So these were 2020, and these are all as they relate to opioids. So children in foster care due to parents that have substance abuse, we are in the middle quantile, sorry. Cumberland's at 43.3, and we're at 31.1. So they're still a little bit higher. With respect to harm reduction, so these are community naloxone reversals. This is 2021 data. The Cumberland is at 1.2, and Onslow is at 0. Treatment and recovery, this is law enforcement reversals, we're low. Treatment recovery, patients receiving buprenorphine, this is 2020 data. Cumberland's at 0.4, Onslow 0.5. And then people served by treatment programs, on average, Cumberland's at 450.1 with an N of 1,510 people. Onslow's at 341.5 with an average N of 676. So, right now, we're doing pretty well. We're not really in any of the high categories except for in our harm reduction with community naloxone reversals, which just means that we're really, out there doing a lot of people out in the community. They also have peer support, number of peer supports as we do. So we're pretty on target with a community that's fairly equal to us.
Thank you. Julia, can you share some numbers with us that you see?
Well, I can certainly say that I think COVID could be part of this, so I want to maybe say that it's COVID. We'll say that maybe it's COVID, but back in 2020, we would see an average of about 30% of our individuals for opioid detox. That was pretty consistent, and we were watching that trend regularly. Alcohol was still the highest at about 50%. Over the course of the last, I would say 6 months or so, that number has come closer and closer. So we are seeing an increased trend in about 40 to 45% of the individuals we serve on any given month here in Onslow County coming in specifically for opioid detox. Now, something that I also want to caveat that with is the fentanyl issue. So what ends up happening is someone might actually be coming in for methamphetamine detox, maybe even crack cocaine use, and they have been getting a batch that has fentanyl in it as well, which is now warranting us to treat them as if they were coming in for opioid use. So that is part of where we're seeing some of that increase. And so I want to say that it's COVID, right? And I hope that maybe that's the only thing that's changing this, and I can't be sure. Perhaps more people know about our services now. That could also be part of that. But that trend did not start until probably September or October. In February, we saw that taper off a bit and it go back to our, about the normal thing that we were seeing. But I can speak to that. I'm not sure if that is consistent across other counties. And so that's just what we're seeing here in Onslow. Those counties, however, keep in mind we're serving 27 counties here at Dick's Crisis Intervention Center, predominantly Onslow, and then following up closely with Carteret and Craven. But the other big counties we serve could be part of that as well when you factor in the other 24 that are coming to our facility.
Lee?
To add to what Julia and Dr. Gilbert just said, as far as the rate of unintentional overdose deaths in Onslow County, we're at a rate of 28.3%. Just like Dr. Gilbert said, we are ranked low compared to other counties in the state of North Carolina. We had 56 overdose fatalities in 2020. I pulled the overdose fatality records for 3 quarters in 2021. Through 3 quarters so far, I have 41 overdose fatalities for 2021. I haven't pulled the 4th quarter yet. But one common trend I have seen as far as overdose fatality is, just like you said, Senator Lazzara, the synthetic opioid fentanyl has been in 66% of the decedent's system. That's what our toxicology reports have revealed to us through the medical examiners. And also cocaine is back on the rise. And polysubstance abuse is a thing that's been around for years, and it's a common trend right here in Onslow County. A lot of the decedents not only have fentanyl in their system, but they have a heroin, methamphetamine, cocaine, and also it's a nerve medication that I've seen in a lot of toxicology reports, and that's gabapentin.
Thank you. Thank you. Very informative. Next question is, how much does opioid addiction cost the state of North Carolina each year in terms of treatment, crime, such as break-in and other offenses, to pay for the addiction? You know, what I can tell you, I guess I can answer part of the question, is I know that a meeting, I'm on the judiciary oversight, and we were talking about juvenile delinquencies in our prison system, and it costs the state $250 per day to house a juvenile, and about $120, I think, for an adult or somewhere in that area. Am I right, Sheriff? State inmate. Okay. So about 60 a day, but $250 for juvenile. But nevertheless, it's a very expensive endeavor. And then on top of that is the millions of dollars that we put towards a lot of different programs. And if those programs are not effective, then we're not really doing anything, and it's costing the taxpayers. Our hospital systems are struggling because their emergency departments are inundated with folks that are struggling, and you know, hospitals or the emergency departments can't turn folks away. And I think I know in our community, we charge off, probably 30 million plus every year, and that's not all related to opioids. But as you know, folks in crisis are going to need to go somewhere. And if they're not able to get into a facility, the emergency room is the next step. And so it costs all of us in this treatment. Anything to add to that you would say? Obviously, the break-ins and the natural crime that the loss from people and that sort of thing, but you can add to that.
Yeah, I would say on top of that, I mean, the factors that would add, I mean, I did go up to the CDC because they did have some information on other states and the per capita, what it costs. They did not have North Carolina listed, but, they had West Virginia listed, and West Virginia at $7,247
Per person.
Yes, yep. And Maine was a little bit higher. So they estimated for the opioid use disorder at $471 billion, and a cost of fatal opioid overdose estimated at $550 billion.
Incredible.
In total. But I think, the other things we have to think about that go into that cost when you're talking about not only crime and your health care, but thinking about transportation to get people there. When you have somebody that is a dual diagnosis, individual that has both a mental health issue, a substance abuse issue, if they're involuntarily committed and have to be transported halfway across the state, it's costing the sheriff's office the gas, the time to call somebody in if they have to. To drive 5 hours one way and 5 hours back, plus whatever time they're there, however many times a week that they have to give there, plus wherever it is that they have to go, because, when they're going to hospitals, the only local place here is Bryn Mawr, and they can only accept so many people, or they don't accept Medicaid, or all insurance-based stuff, again. So there's all these little hidden costs that are going into these type of responses, even in the community. Our community paramedics, the time that they spend out there with them and going to calls and so forth. When you have a very high call volume, which again is related to, the crisis that we're in, plus the pandemic, I believe, really plays into this. It really just rises or increases that per capita number that we're talking about. And of course, crime goes up as a result. Our violent crimes go up. It's just, it really is a very strong interplay that I don't think everybody realizes. And we really, as a community, become in crisis. And again, I'm going to go back to the very first question we had, and which is we all have to put our heads together and come together as partners and work together to address this problem. And even though I know we all have our own jobs to do, we all have our departments or agencies, whatever, to watch out for, we cannot work in silos. Just can't happen. That's old-fashioned. And we have to find new creative ways. And we've been doing a good job with that, but we need more help than we have. We're moving in the right direction. We need everybody to really address this, because we have great people, we have great minds, but we really got to work together even better than what we're doing to address this. We appreciate what you're doing to help. We also have it upon ourselves.
Well, I think those are great comments, because I think we can all agree that recovery is not a one-step process. Again, we can get folks in recovery, and while they're there, they're doing excellent, but there will be a time where they have to leave that recovery center, and guess what? They need a place to live. They need a job. They need to be able to continue to get the prescriptions that they were given while they were in recovery, because most of the time it is dual diagnosis, and there is some form of medication that is given to them outside of the medicated assisted recovery. They may have depression issues. They have other medication, whether it's blood pressure or other things that they're not able to continue, which causes recidivism, and that's what we've got to eradicate. Where do you see gaps in mental health and substance abuse services here locally? What areas can we continue to discuss and talk about?
We have quite a few. I think many, we've kind of addressed here and there along the way here today, but number one, resources. We always say resources, that's a big word, but when we say that, we're talking about access to care resources. We have a very old model, I think, that exists in our community today, and we're trying to address it. We've been trying to address it, which is we have providers, at least in mental health and substance abuse, too, that is an 8 to 5 model. Well, I don't know how many people have their crises from 8 to 5. And I don't know how many people that are in the situation that many people we work with can leave their job to go to treatment 3 times a week to get either dosings or to go get, see their therapist, and can keep leaving their job to go do that without risking their job. Especially if, unfortunately, they're having to work day labor, or they just got their job after, being in the hospital or whatever. I just don't think that's a feasible model. And so part of it is reshaping and rethinking that access to care. That 8 to 5 just, to me, is just not feasible. We have to find more or be more willing to be flexible in our hours of operations, whether it's staying open a little bit later, whether it's maybe opening hours on weekends, whatever that may be, and adjusting that model, or going to them. And that's what I love about our community paramedics, is that we utilize them a lot because they will go to them. And, which addresses our transportation model or transportation issue to some extent. If we can meet our patients where they are, we eliminate that transportation problem to some extent. And we do have the co-responder program, which has been a big help through the county with having mental health ride with them. And so they get a 2-for-1, if you will. But that's not enough. We can't just be one entity. It's got to be more people having that same thought process of how can we treat these individuals better and differently. And so kind of getting out of that old mindset. I think another gap is, and we are addressing it, but again, I don't think it's enough, is having the scholarship fund, because we have many community members, and getting people into treatment and access to paying that upfront first month's fee to get into longer-term treatment. And then the bigger part is knowing when they come back and following them once they come back, because that has been a big problem, and that's been identified through our overdose fatality team, but also through another group that's been kind of following things and looking at those gaps where people go into treatment, when they come out, we don't know they came back. And then they fall right back into those old habits and they have no support. And the crux to recovery is support. So, we're working with 0 Hour Life, who is new to our community, and we are I've already told Mr. Cooper, hope he's ready, because it's coming. We're looking at him as kind of our centerpiece to help us track those people, and with his peer support, do some other stuff, so that they're no longer falling through the cracks. So we're identifying them, but we need everybody to help us kind of get this gap and cost.
That
Being
continuum.
willing to work with those uninsured, get more people who are uninsured onto Medicaid. We're not doing a good job with that at all. We need to be all more responsible about doing that and work with the health department to maybe bring individuals who help people get on Medicaid to our site, in satellite offices or satellite people at our agencies or practice, so that when those individuals come in, they can help them on the spot. Again, addressing the transportation issue, a one-stop shop.
Yeah, I think that's extremely an important piece that we don't do really well with, that continuum of care. While they're in, they're doing great, but as soon as they come out, they don't know what the next steps are, and particularly the healthcare piece is an important piece. Anybody want to add to that?
Sure. And I certainly don't want to keep harping on transportation, but I think one thing that's very unique about Onslow County, as well as a lot of the counties that we serve in Eastern North Carolina, is we are very rural. There's a lot of expansive distance between one place and another. If we were in Mecklenburg County, for example, in Charlotte, we would have a lot more access to getting places maybe quicker. They have a lot of bus routes. They have a gazillion bus routes, right? So I think that one of the challenges is that we're working with a community that may be in the same county, but they're 45, 50 minutes away. And that alone is a huge challenge when you add on how rural our area is on top of the already struggling transportation that we have. Just out of curiosity, has anyone used the Jacksonville public transit system? Mm-hmm. A show of hands. Okay. How was it helpful? Did it help? How many bus routes are there for you? I'm just curious. I have not used it myself, so I don't want to speak for it.
Yeah. So there's routes throughout the city to include the mall, the hospital. Every area of the city has access to a stop, and I think Mr. Jackson's here. He could probably.
Yep.
Yeah.
Can it go to, I'm asking, is it able to go to Sneads Ferry or Richlands?
No.
Okay.
No. Yeah, that's a separate transit system.
Okay. Mm-hmm. So I think that trying to figure out how we can assist our community in this county that is very expansive. That's been a challenge for us at the facility. We do have a transport specialist that's there during our daytime that can assist with getting folks to and from Onslow, wherever they need to get to, whether it's to treatment or post-treatment. But that's one individual when we're serving so many. So I think that that's probably one of our largest gaps in continuity of care, particularly when someone leaves our facility and their appointment might be tomorrow or in 2 days, just ensuring that they have a safe way of getting to that appointment. We've done a better job recently of including a lot of telehealth or virtual platforms, and that has really increased folks' ability to get on. However, we still have folks that have challenges with technology, may not have access to it, or they have a phone that has minutes and things like that. So that continues to be a recipe that we're trying to figure out, like the sweet spot for what is the most effective way to get someone engaged right after they discharge from us. And so we've worked very closely with probably everyone in this room to figure out how we can make that easier for folks and what it is that we need to do to really engage someone once they leave us or after they've gotten to that first appointment. How do we get them to engage in that second and third? That's typically where we see a lot of dropout. So working through some of those challenges with outpatient services. And so again, certainly don't want to harp on transport, but I do think that's probably the easiest excuse that people will give as to why they can't necessarily engage post-discharge from us. So that's something that we're working through.
Thank you. Very quickly, we want to allow some time for a few questions. So let's open up the panel for a couple of questions. But if the panel can please try to summarize your answers, that way we can get more than just a couple in, that would be wonderful. Hold on. If you could state your name and...
Mark Price. What role do faith-based programs play in Onslow County or could play potentially?
Faith-based organizations play an important role in Onslow County. As one of our initiatives under SOAR, and SOAR stands for Strategic Opioid Advanced Response Team. I'm the facilitator of that team as the opioid coordinator at the health department. One of our initiatives and our goals is to reestablish strong partnership with faith-based organizations. I feel like since COVID came into play, that we have kind of lost our relationships with faith-based organizations, but I feel like faith-based organizations play a vital role because they're out on the front line. I just talked to the pastor in the back, and he has an idea of what he wants to do in the community to help people. But I've seen, as being a licensed minister, I've seen where a lot of people, because I have a nonprofit organization myself back at home in Carteret County, a lot of people feel comfortable coming to faith-based leaders or to churches and seeking help because the church should be a hub to help people. So a lot of people coming off the street that are addicted to substances, that have mental health issues, they reach out to some of these faith-based leaders for help. So it's good for us to connect with the faith-based leaders so the faith-based leaders can say, hey, I know this detox facility where you can go and detox. Let me connect you with Julia over there at Dick's. So, yes, it's very vital.
Thank you. Roy Spinett, County Commissioner. Mr. Stiles, you mentioned the need for peer support specialists.
Yes.
Can you explain to us what that means? Who is that? Is that a counselor? Is that a medical professional? What does it take to be a peer support specialist?
Peer support specialist isn't a medical professional. Who they are people who have been through the addiction process, they're living in recovery, and they can relate to these individuals because they've been there. I'm going to be completely honest. A lot of people that are struggling with addiction, they don't feel comfortable coming to law enforcement. They don't feel comfortable coming to public health or any other agency for help. They would rather go to a peer support specialist, somebody that can relate to them, that has walked in those shoes, and they're able to be more comfortable with those individuals. So peer support specialist is a person that will walk with these individuals through the process, making sure they're getting the care they need, making sure they get the resources they need. And anytime, at any period of time, if they're struggling, they can really relate to the person's issues because they've been there and done that. They have to go through a certification program. Yeah. So you have to go to a certification program and get your peer support specialist certification. So you go through the proper training. You're not just out there gung-ho in the streets and trying to help people with no training or certification.
Thank you.
Thank
Next
you.
question.
Vanessa Sapp, can you please comment on the services and resources available for youth under the age of 18 in our county?
Well, 0 Hour Life Center and Miss Heather Perkins that's sitting over there by Mr. Robert Cooper, the CEO of that organization, they just started a teen support program right here in Onslow County for teens that are struggling with substance abuse or have any other issues. And I think that is groundbreaking. That's a big win for Onslow County is to have a teen support program in this county. Good to see you, Ms. Vanessa.
Oh, let me just add to that as well. Heather Perkins, who is my colleague at Jacksonville Police Department, she is on a grant, and she is the substance abuse counselor. Her role is particularly tied to the school system. So she works with the schools, working with individuals and families that have substance abuse problems. So she will work with the school personnel, she'll work with the individuals, she has been to their homes, puts in treatment plans, assists with getting individuals in, she has actually gotten into treatment, as well as development of other programs within our county and city limits, and she has just done some phenomenal work. And she has some other things that she's got coming down the pipe here pretty soon, so.
If I can ask maybe Heather to stand up so we know who you are. Heather, please stand. Let's give her a round of applause. She's a new team member. Thank you, Heather. Lorette, back to you.
My name is Michael Nareski. I happen to be a North Carolina certified peer support specialist. I'm also a national certified peer support specialist. To piggyback off of what Lee had to say, to become a peer support specialist, yes, there is training. The training comes through the University of North Carolina School of Social Work. That's where the certification comes through, okay? There's background checks. There's also one important thing. It's about our own lived life experiences more than anything else. We are not counselors, okay? We are not clinicians. But we are that concrete that's under your feet right now. This opioid addiction, which intertwines with the mental health disparities that people have because of the housing, because of food. The peer support, if you have Medicaid, a peer support, an individual with Medicaid can get 5 hours a week with a North Carolina peer support specialist assigned to them. That means that individual that doesn't have transportation has it because that individual needs medication, usually because of the lived life experience of the peer support, they know where to get that medication for that person. They know the doctors where to go. They know to bring them to Port Human Services for assistance in their mental health disparities. Okay? The peer support, and I tell you this, there's 3,900 peer supports in North Carolina. Other than Carteret County, it only has 2. Onslow is the lowest. Right? Other than now that rate has come up because of one mainstay. The military. Okay? Paul and his group, okay, they brought individuals as peer support specifically for the military, their situation. Okay, of the 3,900 currently in the state, 1,600 are currently working as certified professionals. And it's a number that is grossly underused. Grossly. Because the bulk of the individuals working are working directly only because of Medicaid. And by the way, in that transportation thing, because people don't know, Medicaid has something called motive, and people don't know it. And individuals where the peer support make sure they know that. And that's what a peer support is.
Thank you. Any other questions? Right here.
And Mike, this will be our last question.
Thank you.
For people's time. Here you go, George.
Thank you, Ms. Loretta. Senator, ladies, sir. So question, we were talking about statistics and information. My name is George Papistrat. I own Tideline Marine in Jacksonville, North Carolina. Of any of that, does that include active duty military and their spouses? And then I guess it's kind of like a compound question. So does that include the DoD assets, if you will? And then do we know the percentage of those in the statistics, either OD or drug-related, that are veterans or that had mental health issues from that? I guess would be my question.
Thank you. Anybody want to tackle that?
So I can half tackle that. We don't actually see a lot of active duty, given that they are still required to access resources at Naval. We've had maybe 2 instances in which they've been approved to use our services, but they do have to seek for Alpha or the hospital level care on base. We do see spouses. A lot of times, though, they have TRICARE, so there are more options and availabilities for them to seek. So that's why we don't see as often an individual with TRICARE or a spouse. And believe it or not, we have a fairly low veteran population that we serve at the facility. So I don't actually have a good number to provide you as far as that goes, because our military and veteran population is so low at the facility.
And what
I know
will
the base has some programs that, go ahead, Dr. Gilbert.
That is correct. And what I will tell you is from our community paramedic program, I know that we will serve, and through the PD, we do see veterans that live and active duty we serve that are in the community. But the response is that they have a choice. They can either go to Onslow or they can go to Naval, and they have that option. But again, like Julia was saying, they have to be treated on base. The veterans don't. So the veterans do get treated within the community. But the active duty the protocol is they have to go to base. Now, the base numbers we don't have. Those aren't readily available to us. So these stats, some of the stats that we have are not going to include the base numbers. They're only going to be the ones that we treated within the county limits off base.
Thank you. Can we give them a round of applause, please? I think maybe one. Okay, all right. Thank you all for being here. Thank our panelists. We appreciate all of you, and I'm going to turn it over to Lorette to close us up. Thank you.
Well, you took care of a lot of it for me. Again, I was going to thank the panelists, thank Onslow Memorial for their sponsorship, and I know that there were some folks that still had some additional questions. If my panelists would be so kind to just hang around for a couple more minutes. And I want to thank you to the City of Jacksonville Media Services for recording today's program. Ladies and gentlemen, we are adjourned.